is Rebekah Fenton from Seattle Children's Hospital, and her talk is Breaking the Mold, Communication in Medicine.
Hello everyone, I just want to let you know that if there's anything that I say that inspires you, please share it on Twitter. My account is my name, Fenton, MD, and I'm a storyteller, so I'm just going to jump in and get started. Here's what's been bothering me, doctor. I've been having stomach pain every day for the last few weeks. I'm not really sure what's going on. It seems like that explanation was only 11 seconds. The median amount of time that a doctor listens to a patient describe their reason for coming in. A recent study analyzed how long doctors actually listen to patients describe their concerns, and the result was that they interrupted frequently. And these interruptions didn't include open-ended questions or statements like, "Tell me more." Instead, they actually stifled the discussion with yes or no questions like, "Do you have any diarrhea?" What's worse, the majority of doctors didn't even ask the patients why they came to see them. When I think of careers known for their communication skills, I'll be honest, doctors just don't come to mind. For starters, we notoriously write like this. And these doctors must be marching for a good cause, but I couldn't tell you what. Writing aside, communication is a part of our everyday work. Doctors spend hours talking to patients, getting consent for surgical procedures, revealing a serious diagnosis, counseling on healthy behaviors, and offering advice. My father, who is both in the audience as well as a general pediatrician in California for 24 years, he was my first physician role model. The sound of his pager going off in movie theaters, on long car rides, and during family dinner was the background noise of my childhood. But no matter how many pages he received or how late they came in, he answered each one with patience and understanding. I once overheard a father ask my dad if his child should come into the office because he was sneezing after rolling around on the floor at a birthday party. My dad explained in the most calm and patient voice that the child was okay. And after hanging up, he told me, "I know this dad. He cried when his son got his first vaccines." And that's where medical communication succeeds, at the intersection between openness to learning about your patients and using that knowledge to adapt to their needs. So let's talk about where that breakdown in communication occurs. First, medical language. As all scientists know well, the use of a common language allows for ease of communication across institutions and even countries. Yet the development and maintenance of a separate language becomes a barrier to understanding for those outside of our communities. The more familiar we are with the new language, the less adept we potentially become at explaining those concepts back into lay speak. I call this process unlearning English. It is especially pronounced in medical school, which is often described as learning how to drink from a fire hydrant because of the sheer volume of information. Medical students learn 55,000 new words over 4 years. In comparison, most adults have a vocabulary between 20 and 35,000. Even I found myself stumbling in the process between balancing medicine and communication. During my emergency department rotation, a woman came in by an ambulance with severe respiratory problems. My medical team asked me to get consent from her husband for intubation, placement of a breathing tube through her mouth into her trachea to be connected with a ventilator. My mind was all over the place, thinking about how urgently this woman needed help, but also trying to remember all the risk I needed to mention to her husband. He readily signed, but then I noticed a confused blank stare on his face. I could tell he had no idea what he just agreed to. So I asked him, "Sir, do you know what intubation is?" He shook his head. After I took the time to finally explain, he nodded and his demeanor relaxed. "Oh yeah, she's had that before." These misunderstandings over terminology are unfortunately common and occur in all medical specialties. For example, words like fracture and sprain are commonly used by pediatricians and orthopedic surgeons. Sometimes my dad's patients get falsely excited. "Oh good, it's just a fracture, the arm's not broken." In a survey of adult patients at an orthopedics clinic, only a third could define the term fracture. Sprain was even more confusing. Only 1 in 10 could identify the correct definition, and that was with the help of a multiple choice test. The solution is actually simple. When introducing a medical term, doctors should immediately follow it up with a lay explanation. Here's an example I might use in clinic. Your child has otitis media, an infection behind the eardrum. I'm going to prescribe an antibiotic, a medicine that fights off bacteria to treat that infection. But the problem is doctors are frequently missing these opportunities. In a study of recorded conversations between patients with diabetes and their doctors, over 80% of the visits had undefined medical jargon. On average, each visit had 4 terms unexplained. So when I first meet a family, I try to over-explain the medical terms, and I use pictures to explain complex concepts. I ask about their background so that I can match my level of detail to their health literacy. And I pay close attention to the words they use to get a better understanding of their knowledge base. So if they're a family of doctors, for instance, I reel all that extra stuff in. But I'm always on the lookout for those subtle signs of misunderstanding, like that blank stare. I found the following story on Twitter shared by a Black medical student that exemplifies the harm of missing that critical expression. A Black man in his 30s came in with 1 week of left leg weakness. His brain MRI showed multiple sclerosis, a chronic autoimmune condition that affects the nervous system. Here's what happened next. He has a bit of a blank stare as my attending tries to explain what he has. Now, we're telling him he doesn't have a stroke, but he's clearly processing. So we're running the patient list after rounding, and as we got to him, my attending says something like, I don't know if apathy's the word, just seems like he doesn't care. He laughs, and so does the rest of the team. The medical student was the only person who didn't laugh. Instead, he went back to the patient room, asked him if he understood, then explained the condition in further detail, as well as what it meant for him long term. The patient's face lit up with understanding. Oh, so it's a brain thing I got. He now understood his condition, the necessity for further testing, and what it meant for him long term. Knowledge is power. The student's story ends with the following quote, all because I could recognize what everyone else seemed to miss from a cultural perspective. He's not apathetic, they just weren't connecting with him. This story illuminates the second major area where patient-doctor communication breaks down, along cross-cultural lines. To understand how these issues arise, it is important to know the diversity of the physician workforce and how that compares to the general US population. Only 9% of physicians identify as either Black, Latinx, or Native. These groups combined make up 1/3 of the US population. Ideally, physicians should reflect the diversity demographics of the communities they serve, but in reality, patients of color are more likely to see a physician who does not look like them. All physicians have the equitable responsibility of providing culturally appropriate care. So what does that look like? Initially, the medical community thought that cultural competency was the solution. If I am competent in a particular culture, I can comfortably practice with patients from that group. Sounds good, right? But then the definition of competence is the ability to do something successfully or efficiently. So then I can be competent in putting in stitches or doing a thorough physical exam, but I can never truly be competent in knowing what it means to be from a particular group. Even my experience as a Black person is unique to me. It can vary significantly from others.
Amen.
The concept of competency also breeds stereotypes, like this page from a nursing textbook that was shared on Facebook by a wellness advocate named Onyx Moore. The section attempts to highlight diversity by describing differences in pain response based on culture. Here are some of the quotes from that section. I just want to give everyone a few moments to read these as if you were a nursing student. Imagine if you identified with one of those groups. How would this information lead you to treat patients? Also note that the white experience is missing from the descriptions. White patients, therefore, are seen as the norm. Their experience of pain are allowed to be individualized and dynamic, while other racial and ethnic groups are summarized into these monolithic statements. These facts are not only racist, but have no biological basis for their generalizations. Thankfully, this post went viral. The company promised to pull the section from the textbook and review their other resources for stereotypical content.
Way to go.
Sadly, though, these assumptions are deeply ingrained into medical knowledge and practice. So let's see what happens when doctors actually believe that Black people report higher pain intensities than other groups. When white medical students and residents were asked about false but biological beliefs, over half of them actually believed that white people have thinner skin than Black people. Those who scored higher on this false biological belief scale were also more likely to underrate and undertreat a Black patient's pain in a hypothetical scenario. Under-recognition and under-treatment of Black patients' pain compared to their white peers is unfortunately a long-standing issue that has been verified in several research studies. Children aren't even exempt from this bias, and as a pediatrician myself, that breaks my heart. Emergency medicine doctors did an analysis of racial differences in pain management for appendicitis. This is a diagnosis with little subjectivity. Usually you either have it or you don't, and if you do, it is really painful and intravenous opiates are recommended because children are not allowed to eat or drink until after surgery. So even with a clear diagnosis, a clear treatment option, and high reported pain scores, Black children were still significantly less likely to receive opiates for pain relief. Pretty depressing stuff, right? I shared how first doctors become so comfortable with medical language that they forget how to actually communicate with people, and how they internalize both harmful and incorrect assumptions about patient groups that negatively affect medical practice. Perhaps you've experienced this personally, or through a family, friends, healthcare experience. Maybe you've read this in a recent news story about health disparities. I too had good and bad experiences with doctors growing up. I just thought when I started medical school that there were good doctors and bad doctors. So of course I wanted to be one of the good ones. But then I found myself making mistakes that I thought only bad doctors would make. Sometimes I didn't explain concepts clearly and I left my patients confused. Other times I made assumptions about a different culture. This is not an individual issue. It is a broken system. Most medical students start school with the best intentions, and we're taught to conform our communication style to what I call a one-size-fits-all approach, or the cookie-cutter model. We approach every patient and family with the same perspective, and we only adapt if we're asked. It works for some, but then it just fails for everyone else. Instead, I choose to break the mold. I decided I would no longer make people adapt to my approach. Instead, I would ask about their needs and adapt to them. Cultural humility helped me make this shift. In 1997, two physicians I deeply respect, Drs. Melanie Turgelon and Jan Murray Garcia, introduced the concept of cultural humility to the medical community. Here's how they defined it: a lifelong commitment to self-evaluation and critique, to redressing the power imbalances in the physician-patient dynamic, and to develop mutually beneficial and non-paternalistic partnerships with communities on behalf of individuals and defined populations. Cultural humility teaches that the patient is the expert of their own life and experience, and that every family has its own unique dynamic, set of traditions, and cultures. Providers should seek to learn from them instead of relying on assumptions or previous experiences as shortcuts to understanding. Cultural humility also recommends that physicians are taught to use self-reflection to both identify their cultural biases and address them. It has been over 20 years since cultural humility was introduced. While all accredited medical schools are required to provide cultural competency training, few actually teach cultural humility. The faculty at Harvard Medical School created a cultural humility course and found that after completing it, students reported increased awareness of unconscious biases and acknowledged that providing equitable care and treatment would require a lifelong commitment. The Harvard faculty published their work so that other medical schools could learn from it and implement other similar courses. The culture is changing, albeit slowly. System problems need system-wide solutions. So I'm working with a group of residents and attendings at Seattle Children to elicit communication preferences right away through the use of an All About Me poster. Currently, these posters can be found sporadically throughout the hospital and usually ask questions about patient interest or provide space to post pictures. We've created our own that also asks about family structure, language preferences, as well as the best way to provide updates. This project has the potential to form stronger relationships between families and patients and their providers by giving them the opportunity to say what's important to them, both early on and in a standardized way. We hope that one day soon, every inpatient family has the opportunity to share this vital information with their healthcare team. I am in awe of science, and I love that medicine has the potential to change people's lives. But our work as scientists has insufficient impact if it does not serve everyone it is intended to. How we communicate determines the effectiveness of what we do. Maya Angelou perfectly described the transcendent power of relationships between individuals with her words. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. It is our duty to not only do great work, but share it in a way that celebrates diversity and equitably serves our communities. Thank you.